USMLE style question on normal pressure hydrocephalus, NPH. Question. A 75-year-old man is brought to the clinic by his daughter due to progressive difficulty walking over the past 6 months. She describes his gait as slow and unsteady, as if his feet are glued to the floor. He has also experienced frequent episodes of urinary incontinence and mild memory impairment. Neurologic examination reveals a broad-based, shuffling gait with difficulty initiating movement. Fundoscopic examination is normal. MRI of the brain shows ventricular enlargement without significant cortical atrophy. Which of the following is the most likely underlying mechanism of this patient's condition? A. Loss of cholinergic neurons in the nucleus basalis of Meinert. B. Expansion of ventricles compressing the corona radiata fibers. C. Deposition of beta-amyloid plaques and neurofibrillary tangles. D. Inflammatory demyelination of central nervous system white matter. E. Ischemic damage due to chronic cerebrovascular disease. Answer: B. Expansion of ventricles compressing the corona radiata fibers. Explanation: this patient presents with the classic triad of normal pressure hydrocephalus. 1. Gait disturbance, magnetic gait, feet appear stuck to the ground. 2. Urinary incontinence. 3. Cognitive dysfunction, mild, frontal lobe-like symptoms. Key features of NPH. Idiopathic CSF accumulation leads to ventricular enlargement, episodically elevated CSF pressure, but normal overall ICP. No significant cortical atrophy distinguishes it from Alzheimer's. Ventricular expansion compresses the corona radiata fibers, leading to impaired signal transmission, especially affecting gait and bladder control. Diagnostic test. MRI-CT, ventricular enlargement without significant atrophy. LP, high-volume CSF removal test. Temporary symptom improvement. Treatment, ventriculoperitoneal VP shunt to relieve CSF accumulation. Why not the other options? AA, loss of cholinergic neurons in the nucleus basalis of Meinert, seen in Alzheimer's disease, which presents with progressive memory loss before gait issues. C, deposition of beta-amyloid plaques and neurofibrillary tangles, characteristic of Alzheimer's disease, which causes gradual memory decline without the NPH gait pattern. D, inflammatory demyelination of CNS white matter, seen in multiple sclerosis, which would cause relapsing remitting neurologic symptoms, optic neuritis, and UMN signs, not a classic NPH triad. E, ischemic damage due to chronic cerebrovascular disease, seen in vascular dementia, which presents with stepwise cognitive decline and focal neurological deficits, not ventriculomegaly. Take-home point: normal pressure hydrocephalus, NPH, should be suspected in an elderly patient with the classic triad: magnetic gait, urinary incontinence, cognitive impairment. It is caused by ventricular enlargement compressing the corona radiata fibers, and it can be reversible with a VP shunt. Would you like a